pediatric disease includes two subtitles, non-tumoral and tumoral disease. Non-tumoral disease includes congenital anomalies, perinatal infections, prematurity and fetal growth restriction, neonatal respiratory distress syndrome, necrotizing enterocolitis. I explain all of them for you. Two titles are including SIDS and fetal microbes. I prefer to delete these titles for you because I think these titles are present for you in next terms and staging period.
So which ones will be deleted? Which ones will be deleted?
SIDS and fetal microbes. These titles, I think, in my opinion, these titles is not necessary for you now. After that, after necrotizing enterocolitis, I talk about tumors and tumor-like lesions of infancy and childhood. Okay?
Okay.
Pediatric disease, most of them have genetic origin, but the others one are not genetic. Others that are not genetic are unique to children or distinctive form of them are present in the childhood period. Most of them have genetic origin, and the others are unique to children period or take distinctive forms in the patient population. They have two terms, infancy period and neonatal period. Do you know differences between them? Infancy period and neonatal period.
Neonatal is are younger than infants. It's the first month of life, but infancy is the first year.
Exactly, that's right. Infancy is the first year of life, but neonatal period is the first 4 weeks of life. We don't use them instead of infancy is the first year of life, and that is in the highest risk of death from the pediatric disease. But neonatal period is the first 4 weeks of life and is the period of life that is most hazardous time from pediatric disease. This table shows you some causes of death by age. All of childhood period from birth to 14 years old. Childhood period is defined as at the birth to 14 years old. This table listed some causes of the deaths by age separately from birth to the first year of life, from the first year to 4 years old, 5 to 9 years old, and 10 to 14 years old. And you see that most causes of death in the first group, younger than 1 year, is congenital malformation. But the others, accidents are the most important cause. In the first edition of the Robbins book, you see that the last group, 10 to 14 years old, at the top of the list, firearm-related injuries are located. After that, accidents is located. From the birth to 14 years, you see congenital malformation is from top of the list and less than years old to end of the list in 10 to 14 years old. And accidents are the first reason, first cause of the death, and 1 to 9 years old. Okay. I want to talk about congenital anomalies. Congenital anomalies are the structural defects that are present at birth, including cardiac defects, renal anomalies, or such deaths that may not be clinically apparent but are present at birth, are present at birth by definition. Congenital anomalies are structural defects that are present at birth. Term congenital does not imply or exclude the genetic basis. It may be genetic or not, may not be genetic, but they are present at birth. Congenital anomalies include some subtitles: malformations, disruptions, deformations, and sequence. All of them are congenital anomalies. Malformation. What does mean malformation? A primary errors of morphogenesis means malformation. Prefix of mal means
incorrect or
bad. Malformation. Formation means malformation means an error in morphogenesis that is present primarily, and an intrinsically abnormal development process as causes of malformations. Usually are multifactorial and may be present in several patterns, from local feature or manifestations such as syndactyly or polydactyly to lethal forms such as holopresence-poly. Do you know syndactyly or polydactyly? What is syndactyly or polydactyly? Do you know? What is polydactyly?
Having more than 5 fingers.
Yeah, having more 5 fingers means polydactyly. But syndactyly means
having fingers which are connected to each other.
Adhesion, yeah. Adhesion of at least 2 of fingers adhere with each other, and that can be removed with a simple operation. It's a simple feature of the congenital malformation, but some of congenital malformations are have a little manifestations and lead to stillbirth and associated with little malformation, such as mid-face structures are fused or ill-formed, and so they have many different manifestations. These slides show for you some other examples. You see in this photo a presentation of the polydactyly, and this one is syndactyly, and this one is cleft palate or lip palate. The formation of the palate is not sufficient, and so it may be present in the face as cleft lip. Okay? And all of them are congenital malformation, primary role of morphogenesis. Another one is disruption. Disruption is result from a secondary destruction of an organ or body region that was previously normal in development. But a congenital malformation morphogenesis lead to abnormal feature. So they are not heritable. And of course, they are not associated with risk of presence again or recurrence in subsequent pregnancies. You see in this picture a band of amniotic membrane around the fetus. A thin band is separated from amniotic membrane and encircled around the limbs of the fetus or around the umbilical cord and lead to insufficient perfusion. This event is an extrinsic disturbance that leads to an error and so-called disruption. But morphogenesis is intrinsically normal against the congenital malformation. Okay? This can lead to amputation of the organs if this amniotic band encircled around the ankle, fetal ankle or fetal fingers. It can lead to organ amputation and so-called disruption. Do you understand the differences between congenital malformation and disturbance and disruption?
Yeah.
The other one is deformations. Deformation is in fact represents an extrinsic disturbance of development rather than an intrinsic error, but mostly is like to disruptions. The most common in any cause that lead to compression on the fetus, maternal or fetal. For example, a small uterus or first pregnancy that's in a first pregnancy that the uterus is not sufficiently opened and malformed or bicoordinated uterus or presence of leiomyoma in for example, intramural leiomyoma or submucosal leiomyoma in the uterus can lead a smaller space for fetus to develop. Or another conditions such as fetal conditions, for example, multiple fetuses or oligohydramnios or abnormal fetal presentation, all of them can make a smaller space for development of the fetus, so localized or generalized compression of the closing fetus by abnormal biochemical forces can lead deformations. Uterine constraint is the most cause of the deformations. Okay. Maternal deformation. Okay. Do you know what has been oligohydramnios?
Too much amniotic fluid.
Too much?
You said oligo?
Oligo.
Oh, okay, oligo, too little.
Too little.
Yeah, I thought you said poly.
Too low amniotic fluid because of leakage of the amniotic fluid from the amniotic membrane and because of each reason. Leakage of the amniotic fluid that is surrounded the fetus lead to less movement of the fetus. So compression of the uterus of a fetus is more than before, and deformation would be happening. And the last one is sequence. Sequence, oligohydramnios is the best example for sequence. In the sequences, you see some events. The first event is cause of the second event. The third event and the second event is the cause of the third event. So, in the sequence is a cause-effect relationship between the events. You see the oligohydramnios, leakage of the amniotic fluid is present, and oligohydramnios lead to fetal compression. Fetal compression lead to bridge presentation or altered faces or positioning defects of feet, hands. These events have a cause-effect relationship with each other. Amniotic leakage lead to oligohydramnios lead to fetal compression, and fetal compression lead to such events such as pulmonary hypoplasia or positioning defects of feet or hands or bridge presentation. But in syndrome, you have John? Okay. But in syndrome, you have a cause that leads to 1, 2, 3 without any cause-effect relationship. There is a cause that leads to 1, lead to 2, lead to 3 events, okay? Without any relationship between the first or second or third events. These are differences between sequence and syndrome. Okay, so oligohydramnios or Potter is a best example or an excellent example for a sequence. Okay, all of them were congenital anomalies, including congenital malformation, disruption, and deformation, and sequence. Okay, isn't there any question?
No.
Okay. Another title is organ-specific malformation. Organ-specific malformation includes some terms that you should know. Do you know definition of agenesis, aplasia, hypoplasia, and atresia? These are different with each other, and sometimes students have mistakes to use of them instead of them. Agenesis means?
It means when something doesn't form, organ doesn't form.
Doesn't form, completely absent of an organ. For example, a kidney completely absent, doesn't form at all, not at all. But aplasia or hypoplasia means the organ is formed, but this formed organ is not grows definitely or well, is not grows well. Incomplete development or underdevelopment means aplasia and hypoplasia. Aplasia means the organ is formed but has not developed or has not grows enough. Hypoplasia, um, hypoplasia means underdevelopment. And so agenesis is not absence of the organ is not formed, but aplasia means the organ is formed but not development is present. And hypoplasia means development is present but is not enough. Okay? Atresia is different with them. It means absence of an opening. And we talk about an organ that had a lumen, such as esophagus or GI or bile ducts. All of them are a lumen, have a lumen. So absence of an opening and the organ that have lumen that leads to an atresia. They use the term of atresia in such situation. Okay, you see in this slide some photos. The first one, A. Which one of the terms that I said in the previous slide is true about this one? Agenesis, okay. And this one?
Aplasia.
Aplasia, formation is present but development is not present. And this one? Hypoplasia, underdevelopment. And this one? Normal esophagus. And this one is?
Atresia.
Atretic esophagus. Yeah, atresia. Okay, etiology of the congenital malformation. Causes of congenital malformation may be different. 40 to 60% of them are unknown causes. And the other one that are known may be genetic causes, environmental influences, or maybe multifactorial inheritance. At this table, you see all causes of the congenital malformation that you can read down after the class. Maternal infection or maternal disease status such as diabetes or endocrinopathies, drug consumption such as alcohol or thalidomide or warfarin, Roacutan, all of them maybe affect the fetus and lead to congenital malformation. Genetic causes from known causes. Genetic causes, for example, chromosomal syndrome, such as Down, Turner, Klinefelter, all of them may be present during gametogenesis and hence are not familial. And the other feature of genetic causes such as single gene mutations may be present. Or environmental influences, viral infection, drugs, or radiation during the pregnancy, maternal rubella, maybe torch infections, torch infections? Torch infections.
I don't remember T, but R is rubella. C is cytomegalovirus. Toxoplasmosis. O is other diseases like varicella and
Good job.
I don't remember probably the varicella.
Including syphilis, rubella, and C, cytomegalovirus, and herpes virus. Okay. All torch infections viral infections, drugs, radiations. Viral infections include storage and during pregnancy or some drug consumptions. Thalidomide can lead to knee malformation. Alcohol contributed to fetal alcohol syndrome, or cigarette smoking, or diabetes mellitus of the mother. You see in this slide a photo from a fetus that is affected by alcohol consumption by his or her mom. You see some manifestations such as microcephalus, low nasal bridge, epicanthal fold, internal epicanthal fold, and you see normally two projection between upper lip and nose. These are two lines, so-called philtrum. These are so-called philtrum. In this fetus, these projections or philtrum are absent because of fetal alcohol syndrome. And microkinesia, all of them are manifestations of the fetal alcohol syndrome. Smooth philtrum, so-called smooth philtrum. This photo show for you comparison between a normal baby and macrosomic baby. You know macrosomic baby, macrosomia. Macrosomia, what does mean macrosomia? Macrosomia means birth of a fetus with more than 4 kilogram weight. It means macrosomia. That's we see such baby that's born from diabetic mother. Diabetic mother can live to presence of such babies, macrosomic babies. Macrosomic baby have more than 4 kilogram weight at birth. And so they are really chrome and are pink and chrome compared to a normal baby. And this feature are because of presence of insulin or hyperinsulinemia in their blood, and lipogenesis, organogenesis more than normal status, so they are plump and large and pink because of hyperinsulinemia. And insulin is an anabolic hormone and can contribute to birth of the macrosomic baby. Multifactorial inheritance may be environmental and some genetic effects both each other, and the most common genetic cause of congenital malformation are in this group. Cleft lip and palate and neural tooth defects are the examples of multifactorial inheritance. After after consumption of folic acid in the prenatal period, we see a dramatic reduction in the incidence of neural tooth defects. These days, less than before, can see these defects such as cleft lip or cleft palate, because most of the mothers are consume folic acid in prenatal period. Cleft palate or cleft lip may be limited to the bifurcated ovula, or may be more severe Any question? Pathogenesis of the pediatric disease are two general principles that, regardless of etiologic agents, may be causes. For example, the timing of presence of the prenatal teratogenic insult is really important. The timing of the presence of teratogenic insult can lead to occurrence or not occurrence of the effects, or the type of the anomaly that can influence by the timing of the presence of insults. At the first weeks of the intrauterine life, so-called embryonic period, the effects are more serious. And the first 9 weeks, that so-called embryonic period, abnormalities are more major and more serious than the rest of the intrauterine life until the birth. You see the minor morphologic abnormalities in the rest of the intrauterine life. So timing is important. If the teratogenic insult is and exposure to the teratogenic insult is present in the first weeks of life, intrauterine life, and for embryonic period, you see more serious abnormalities. But if the spacing by this teratogenic insult is present, for example, in 34 gestational age, the effects may be less than serious or less serious, or maybe more minor morphologic abnormalities. And the second point that is important is that we know environmental insults, some of environmental insults often can select a genetic pathway to lead to teratogenicity. For example, some drugs, such as Rocutan. You know many people consume Rocutan for their skin disease, for acne. This drug selects TGF-beta signaling pathway to affect its teratogenicity effect, and or valproic acid can influence the Hox proteins and so on. Okay, I want to talk about prenatal infections now. In 9:15, maybe transcervical or transplacental. In fact, prenatal infections subcategorized into transcervical or transplacental. Transcervical or ascending infections, most of them are bacterial infections such as the streptococcal, alpha-hemolytic streptococcal infections, or viral infections such as herpes simplex. When these infections pass through funnel, birth funnel, so the fetus inhaling these infections that that enter to amniotic fluid. These infections can infect the lungs and all organs of the fetus. So we can lead pneumonia, sepsis, and meningitis. But there are another manner is transplacental infection, so-called hematologic infection. It occurs at any time pregnancy, any time during gestation, may be occur. The most important transplacental infections are those that I mentioned before. Toxoplasma, rubella virus, cytomegalovirus, and herpes virus, and others such as Rhinovirus. These infections may occur at any time during gestation and are most important in transplacental infections. If these infections present in early gestations, cause chronic sequelae in the child. For example, cataracts or mental retardation, growth restriction, or congenital cardiac anomalies. But if these infections present in later in pregnancy result primarily in tissue injury accompanied by inflammation, such as encephalitis, pneumonitis, myocarditis, and so on. Okay. Prematurity and fetal growth restriction. Two different terms, and by definition, prematurity means an infant that can be at first in gestational age with less than 37 weeks. By definition, prematurity is gestational age with less than 37 weeks. The prematurity doesn't refer to the weight of the fetus, but in fetal growth restriction, at the definition of fetal growth restriction, weight is important. The weight less than 2,500 grams at in the neonates that are born at term. So the gestational age is 37, but their weight is less than 2,500 grams. At the prematurity, the point that is important is the gestational age, that is less than 37 weeks. Really, all of them have weights less than 2,500 grams. Okay, because of prematurity, some disease may be present, for example, respiratory distress syndrome or necrotizing enterocolitis, sepsis, or intraventricular damage or intraventricular hemorrhage. This immature neonates are vulnerable to several important complications, such as RDS, necrotizing enterocolitis. Okay, now, immaturity of organ systems in preterm infants makes them vulnerable to several important complications. But fetal growth restriction by definition means the infants who weigh less than 2,500 grams at birth. Fetal growth restriction is made because of some abnormalities, fetal abnormalities, or placental abnormalities, or maternal factors. fetal abnormalities such as chromosomal malformations or torch infections or congenital anomalies can contribute to fetal growth restriction that is symmetric and all organs of the fetus may be affected. But in placental abnormalities such as placental paradia, placental abruption, placental infarction, fetal growth restriction is asymmetric and all organs are not affected symmetrically. Brain is usually spared from relative to visceral organs. Do you know placental paradia? What does it mean, placental paradia?
I think it's when the placenta becomes planted to
Lower
lower, yes,
location,
lower,
lower
and blocks the
position.
cervix.
Lower position, and is previa. Previa means via the birth canal or cervix, and the placenta is blocked the passing from the birth canal at its location is not correct, so can lead to some complications, and insufficiency may be present, placental insufficiency, or in compared to a normal position of placenta you see in this photo. This is placental previa. All maternal factors, they said fetal abnormalities, placental abnormalities, and maternal factors. Most common causes of growth deficit and fetal growth restriction is maternal factors. For example, preeclampsia, hypercoagulable states, or maternal narcotic abuse, alcohol consumption, or maternal malnutrition, drug consumption, such as penicillin. Okay, neonatal respiratory distress syndrome, or RDS, is one of the most complications in the disease that is specialized, almost always seen in premature infants. The most common cause of respiratory distress syndrome in the newborn, and another term, so-called myelin membrane disease, is used for the studies. Primarily disorder of premature infants. Less common cause includes excessive sedation or fetal head injury during delivery. All of them can lead to distress syndrome in the fetus, aspiration of blood or amniotic fluid, but the most common cause is in the premature infants. Pathogenesis of this disease is inability of the immature one to synthesis of surfactants. What is surfactant?
It's fluid which is in the lungs, in the alveoli, and the surface tension from this fluid stops the alveoli from collapsing when there's no air in them.
Yeah, exactly. The surfactants this slide. Surfactants is a complex of phospholipids and associated proteins, surfactant associated proteins and phospholipids form the surfactants. The most important phospholipid of the surfactant is lecithin. Okay? type normal line tissue, and monocytes type 1, type 2 that are lined alveolar spaces. Pneumocyte type 2 can produce and store and secrete the surfactants. In this slide you see, in this photo you see normal alveoli that are lined by pneumocytes type 2 and type 1. Type 2 release the produce and the store and release the surfactant. Surfactant can prevent the collapse alveoli and keep normal tension and all alveoli with different size. So if in a premature infant with synthesis of the surfactant reduced, surfactants in alveoli are decreased, and after that increased alveolar surface tension will happen, and atelectasis happen in many alveoli, and uneven perfusion and hypoventilation is evident. So hypoxemia and CO2 retention after that can lead to acidosis. Acidosis itself augments this circulation, this algorithm, and pulmonary vasoconstriction, pulmonary hypoperfusion, contribute to endothelial and epithelial damage. So plasma leakage is happened into alveoli, and you can see in the schematic photo, you see the endothelial and epithelial damage lead to plasma leakage and presence of many inflammatory cells in the alveoli, and presence of macrophages and fibrin deposition in the inner surface of the alveoli, and you see under the microscope membrane, eosinophilic membrane, that line the inner surface of alveoli. So we call this disease also hyaline membrane disease. Hyaline membrane disease is arise from the pathology features under the microscope. This feature also repeats the previous data. Prematurity led to inability of type 2 pneumocytes to produce the surfactants. So reduced surfactant synthesis, storage, and release led to decreased alveolar surfactants, increased alveolar surface tension for atelectasis, and impaired perfusion and hypoperfusion, hypoventilation, hypoxemia, and CO2 retention. CO2 retention causes acidosis. Acidosis leads to the pulmonary vasoconstriction, pulmonary hypoperfusion, and damages of epithelial and endothelial lining, leakage of the plasma into the alveoli, and presence of inflammatory cells, macrophages, fibrin deposition, and necrotic debris of the necrotic cells. And at the end you see hyaline membrane, eosinophilic hyaline membrane, and the inner surface of the alveoli. All of these events are presenting RDS, or respiratory distress syndrome. A normal lung tissue normal alveoli, compared to the lung with RDS, lung tissue with RDS. You see the atelectatic alveoli, this one, and some of them are hyper-ionizated and lined in the inner surface of them, lying some hyaline membrane disease, includes ferment deposition and you see filtration of inflammatory cells and the stroma. Alternating atelectasis and dilation of the alveoli can be seen in this picture. You see the thick hyaline membrane lining the dilated alveoli. Some hormones can regulate synthesis of the surfactants. For example, corticosteroids stimulate formation of the surfactants. So the presence of RNase and corticosteroid secretion is less probable. And oppositely, insulin suffers surfactant synthesis. So happiness of the RDS is more probable. Labor itself is a stressful condition, so it can be associated with corticosteroid secretion and increased surfactant synthesis can associated with less probable of the RDS. Cesarean section performed before the onset of labor can increase the risk for RDS. This slide also show for you some comparison between normal alveoli with surrounding capillaries compared to an RDS an alveoli that's involved by RDS. You see leakage of the plasma and photon deposition in the inner surface of the alveoli. In your book, Pathology of Robbins' book, you see some form frames that are labeled as morphology. These frames are very important. Read all of them and pay attention enough of them because they explain some data about gross examination or microscopic examination of the related disease. For example, for RDS, this frame explained that in gross examination, unlike a normal RDS has normal size, but is heavier than normal lung because it's airless and is heavy and relatively airless. The appearance of the RDS line is mottled purple color, and in the microscopic examination you see atelectasis of the alveoli, and you see eosinophilic hyaline membrane that I explained for you in the previous slides. You see necrotic type 2 monocytes and extravasated plasma proteins, but these pathologic features are not seen in stillborn infants. After 3 or 4 days or hours after the stillbirth, you maybe see these pathologic features under the microscope. This feature is also a hyaline membrane disease that line the inner surface of the alveoli in RDS lung. Okay. We have a break, and after I prematurity. The more phospholipid level means the more maturation of the lung. So if there is a low level of phospholipid in amniotic fluid, so prophylactic administration at first of exogenous surfactant is a way to prevent the presence of RDS or happiness of RDS. Recovery begins to occur within 3 or 4 days. Oxygen as a treatment for RDS infants after presence of happened of this. After oxygen therapy, there are some complications. That these days, these complications are not really present because the policies are shifted to prevention of it. These complications are retinopathy of prematurity and bronchopulmonary dysplasia. Retinopathy of prematurity means proliferation of the capillaries in the retina. So these infants, after treatment of the RDS, may have some problems about their visual activity because of hyperoxic phase can lead to downregulation of the VEGF and the endothelial cells at their retina. So endothelial cell would be apoptotic. After the stop the oxygen therapy, VEGF level rebounds and leads to neovascularization because VEGF is a growth factor. So neovascularization leads to vessel proliferation at their retina. So retinopathy of prematurity is a complication of the oxygen therapy in the RDS infants. Another complication is bronchopulmonary dysplasia due to oxygen therapy. Bronchopulmonary dysplasia means a striking decrease in alveolar septation. So they have simplified alveolar structures compared to normal alveolar structures. So they have a dysmorphic capillary configuration, and is another complication due to oxygen therapy in RDS infants. Multiple factors such as hyperventilation, prematurity, inflammatory cytokines also are present. Okay,